Now let's just break it down into pieces here. So let's talk about just very briefly consolidation. Using consolidation in everyone, using it only in people who are not in complete remission, Paul?
We have been deploying consolidation and building on the IFM DFCI experience of 2 cycles of RVD. Obviously in the CTN study, which we participated in, there were 4 RVD. The thing that was interesting to me in the data, Amrita, was the high-risk group, that in fact there was a 48% progression-free survival in favor of the RVD consolidation compared to 40% for the tandem and the no RVD consolidation in the other 2 arms. Now, I think that's interesting because therein may lie a clue. So our policy is consolidation is reasonable to consider, particularly in high risk, and I would include in that category patients who don't achieve a complete remission to intensification.
And what about maintenance therapy? It seems all of these trials use maintenance routinely now. Sagar, is the question answered and finished? Everybody should be on lenalidomide maintenance. And the English had an updated of their trial with lenalidomide maintenance. Maybe you could comment on that as well.
Yeah, no, I think you know, across the board, certainly in the meta-analysis as well as the English, the MRC trial.
I mean, the audience may not be familiar with the meta-analysis, so why don't you tell them what that was?
So the meta-analysis is data that was presented actually at ASCO last year that looked at the CLGB study, which was the US trial of len versus observation. It looked at the French trial, which was also len versus observation, and it looked at the Italian study, which was len versus observation as well. And previously, I don't think, other than the US trial, the other 2 were not necessarily showing an improvement in overall survival. But when you aggregate all 3 of those trials, there's a clear improvement in overall survival with very long follow-up supporting len maintenance. The MRC trial, I think, continues to support that concept of lenalidomide maintenance improving duration of response. And I think what is really quite striking is the only group that doesn't necessarily benefit from len maintenance are the high-risk genetic subset. And so I think there is a role here for tailored maintenance therapy. It's clear to me that patients benefit from maintenance. The HOVON study that was published years ago looking at bortezomib in the maintenance setting suggested benefit for high-risk subsets. And then we've published a small series of patients suggesting that an IMiD and a proteasome inhibitor together really can alter the natural history of patients with 17p deletion. So I think there is a tailored approach to maintenance therapy. And at our center, for instance, standard risk would get lenalidomide. High risk with 17p would get RVD as maintenance, and 414s would get bortezomib as maintenance therapy. And that's just an example of one way to think about it.
I think a lot of people are doing that. I want to ask Saad, it seems like the question of whether to use lenalidomide maintenance is answered. The question now becomes how long for, and whether there are minimal residual disease type of techniques that one can use to decide when to stop. So I would like to know what your practice is and how long you treat for.
So right now, based on the CLGB 101-104 trial data, you know, and this meta-analysis that was just presented at ASCO earlier this year, you know, our practice is to continue len maintenance until relapse or progression or intolerance. But I think you ask a very important question. You know, do we really need to continue patients on maintenance therapy if they are MRD negative? I think this is an important question that Paul and I believe Pete Voorhees are trying to develop an answer for within the Lions. I'll turn it over to...
Well, I would agree with everything that's been said, Keith. I think the important point, though, is that in terms of continuous therapy, we have a slightly different approach in that we use lenalidomide as a backbone in everybody, and we do exactly as Sagar does, where we deploy bortezomib in higher risk. But in the 414s, for example, we wouldn't necessarily exclude lenalidomide. And our rationale behind this is that this continuous therapy model has been validated again and again. And it's worth mentioning that the OS benefit from lenalidomide until progression in the meta-analysis was 2.5 years in OS benefit, which was really, to me, the most striking thing.
The British group did a little clever analysis where they looked at people who came off lenalidomide after a year for toxicity, not for disease progression. They compared those to people who stayed on What did that show us, Paul, if you can recall?
I can recall it showing continued benefit, and I think that's important.
And otherwise, the ones who didn't stop did better, right?
Well, those who didn't stop did better, but there was still continued benefit from those who had to stop for toxicity. So no, I see your point, Keith. In other words, staying on therapy was better than not.
Right.
Absolutely correct.
And,
yeah.
and the other anecdote that they showed, I'm just jumping in here, you know, they actually had a subset of patients within that study where they actually looked at the gene mutational load at baseline compared to at the time of relapse in patients who were on LEN maintenance versus not. And they did not find any meaningful differences between the two. I think it's a smaller subset, but it leads to a very important point. You know,
I guess I'll tell you, I'm a little bit different. I don't keep people on lenalidomide forever because I do worry a little bit about the toxicity in the bone marrow. So I have been using minimal residual disease testing as a guidepost for whether to continue, usually at the 2-year mark or somewhere around there. Are you using minimal residual disease testing, Amrita? And if so, what technology do you use?
So we are using it mostly in the context of clinical trials, and then probably more ad hoc. Each individual at our institution is doing it, which I would venture to guess is the same across the board.
Is this flow cytometry or next generation sequencing?
We've been using next generation sequencing.
Is that standard? Are people happy with that? Or?
go ahead.
We use NGS in the context of clinical trials. I will say off protocol, we're careful. And you know, again, does it change management? You know, I would be cautious there right now. We do firmly believe in the continuous therapy model, based on all sorts of data.
I'm an outlier here, but didn't give you a chance to finish. Sorry.
Well, I was going to say, I mean, my curious question to you, Keith, would be, first of all, I think it's not just MRD at one time point, which is the challenge. It's sustained MRD.
Exactly.
And
But
what you would do in a patient who
we'll-
becomes
well,
MRD positive, for example.
Well, we'll start again if they became positive. Okay, I just want to...